Unit 5-6, talking about metabolism, but really it's your endocrine system. So things that we have to understand in Unit 5-6 is our thyroid. If we're producing too much thyroid hormone, that would be hyperthyroidism. If we don't have enough, it'd be hypo. And then on the back of our thyroid, we have four little glands called parathyroid. And those directly regulate calcium. So if we have low calcium, we could say that the parathyroid is not working appropriately. So it would be hypoparathyroid. If we have too much calcium in the blood, that could be hyperparathyroidism. And it is also important to remember what too much or too little calcium looks like in the body. Looking at the adrenal glands, so Addison's and Cushing's. Cushing's is too much cortisol, where Addison's is no cortisol. And Cushing's could be caused by a tumor called pheochromocytoma. We can also look at our antidiuretic hormone, so diabetes insipidus versus syndrome of inappropriate antidiuretic hormone. And then we're going to touch on HHS and DKA. Again, your chapters, make sure if you've got the right book that you're reading the pages provided here. So chapter 54, reading just pages 1302 through 1319. Looking at our electrolytes real quick, because it is important to understand this when it comes to our endocrine system. Our hormones can directly or indirectly affect our electrolytes. So sodium, when we think about sodium, think neuromuscular. Anytime sodium is too high or too low, you're going to have neurodeficits. You're also going to see some muscle twitching, some irritability, restlessness, leading to seizure and coma. So it directly affects the neuron. It is important to remember that we cannot adjust sodium too quickly. So if we have a patient with a sodium level of 160, we cannot drop them too quickly. In the first 24 hours or anytime, but in 24 hours, we cannot go more than 12 milliequivalents of a change in our sodium. So that patient that comes in at 160, we can't bring their sodium down to normal levels in that 24-hour period. By the end of that 24 hours, their level could be 148. And the reason why we can't adjust sodium too quickly is because it demyelates the neuron, and you can't come back from that. You damage the neuron, it's done. In the same instance, if our sodium is too low, let's say it's at 120, we can only bring up that sodium level to 132, so 12 milliequivalents. Sodium is neuromuscular. It affects your neurons, so it's going to affect your level of consciousness, but also patients become twitchy. So what's our treatment for sodium? So if they have too much sodium, we want to kind of give them some fluids to dilute that down. We also want to tell them to decrease the sodium intake, monitor their kidney function. Is something going on where maybe they're not excreting what they should? You're going to be monitoring for fluid overload. And always remember your potassium is always doing the opposite, most of the time, is doing the opposite of your sodium. So if your sodium is going to be high, your potassium is going to be low. And what are you going to monitor for that? Probably a heart attack, right? And this is important to remember. So if we're trying to make our patient pee out that sodium, we don't want them also urinating out potassium. So the diuretic that we could use in this scenario, if their sodium is high and their potassium is low, is spironolactone. That is going to retain the potassium. Now with hyponatremia, we could give them fluids. We just have to be very careful with it because a lot of times hyponatremia could be correlated to fluid overload or being the sodium being completely over diluted. So our IV fluids need to be kind of salty. So that would be your hypertonic 3%. Drugs that promote water excretion and not sodium. So that could be your vasopressors, your vasopressin antagonists. So your TT to go PP, your tolvaptan is going to make you lose some of that fluid, but also retain the sodium. Sometimes you can see lithium being used or other drugs being used, but most of the time it's going to be your vasopressin antagonist, your tolvaptan, or your 3% sodium. Saline, sorry. Now calcium. When you think about calcium, think about nerve impulses. In order to have a good nerve impulse, you need to have calcium coming with the synapses. So if we do not have calcium at that synapses, our neurons become kind of twitchy. It's kind of like they are in like a drug withdrawal. Just an example. So think about if someone is withdrawing from I don't know, cocaine or opioids or benzos, and they do not have that on hand, the calcium on hand, their body it goes into like a withdrawal. It becomes twitchy. That neuron doesn't know how to act without that chemical. So if we do not have calcium, your patient is very, very twitchy. They are high risk for seizures. They're having chopsticks and trousseaus. They are just, everything is just really irritable. Now, if they have too much calcium, I always kind of think about Tums, because Tums is calcium carbonate. If we take too much Tums, our whole goal is to like slow our GI tract down so we're not having stomach upset, right? So if we have too much calcium, things get slowed down. But you also run the risk of building up calcium stones or calcium deposits. So the way that I remember it is stones, because you can get kidney stones, groans, because your stomach is upset, you're kind of constipated, bones, there is, your bones are hurting because more calcium is coming out into the blood and not staying in the bone, thrones, because you're sitting on the toilet and peeing a lot, you're trying to get rid of all that calcium. And then on top of that, there is some depressed or psychosis occurring, so psychiatric overtones. So when you think of calcium, think skeletal and cardiac. Overall, think about that nerve impulse. If there is hyperexcitability, things are twitching, the neuron is withdrawing from that calcium, so it's hypo. If there's too much calcium, things get dulled down. Calcium is important for bone strength. It helps activate enzymes. Do not forget that we need vitamin D, which is a vitamin, but I kind of think of it like a hormone. So your kidney activates that vitamin D so that calcium can be absorbed into the bone. Calcium is regulated by the parathyroid. It is also regulated by calcitonin that is released from the thyroid gland. Calcium also helps with blood clotting. So that was just a quick overview of your electrolytes. Now let's get into the endocrine. So the primary function of the endocrine system is to regulate metabolic functions in the body. There is a close relationship with nervous system. Neuronal stimulation is required for specific hormones to be secreted or in adequate amounts. So hormones are released based on your body's needs to keep you in homeostasis. How does it get released? Well, your neurons are sending out those neurotransmitters. The venous system is involved and various glands are involved. Ultimately, there are, I kind of call them like the CEO of the data center and the middle manager of the data center. Those two things are up inside your head, and they are talking to your organs. They are monitoring, like the baroreceptors. Everything is hopefully talking to each other, saying, your blood pressure is too low. We need some vasoconstriction. Your stress is too high. We need to release some cortisol. Your metabolism is really slowed down. We need to speed it up. So all of these baroreceptors, all of these hormones and neurotransmitters are talking to the hypothalamus and the pituitary gland. So hormones ultimately are going to speed up or slow down the metabolic process. Metabolic, when I say this, it does not mean like you eat something and you digest it. Metabolic is, how's your heart rate going? How's your breathing? Yeah, it does involve your weight. It does involve thought process and your food metabolism. It does involve. But ultimately, metabolic is your cellular energy and how it is working. Hormones can also turn on and turn off glands. So when we look at the body, we are going to be focused. So we have our pituitary gland up here, and right above that sits the hypothalamus, and that's going to be like the data center and the managers. The hypothalamus, I call it the CEO. He tells the pituitary gland what to do, and the pituitary gland is like running the show. So telling like the thyroid, you need to secrete calcitonin because your calcium is high. We need to put that calcium back in the bone. Or we have a big nursing exam. So we're going to secrete some of this cortisol to keep us more alert. Ultimately, these all run together to keep you in homeostasis. So hypo versus hyper. We have this thing called a negative feedback loop. We also have a positive feedback loop. So our hypothalamus and then our pituitary gland. When we have, let's use this picture for example. Let's say our patient has too much T3, T4 out in their body. So they're becoming more hyperthyroid. The thyroid gland is then going to relay a message back up here saying, hey, pituitary gland or hypothalamus, please stop stimulating me to release more hormones. We are good right now. That is called a negative feedback loop. So your hypothalamus releases a releasing hormone that stimulates the pituitary gland. That pituitary gland then stimulates the thyroid gland to release its hormones. But now we have too much. So now the thyroid is saying back up to the pituitary gland, we don't need to be stimulated anymore. That is a negative feedback loop. Our positive feedback loop is just the way that it goes naturally. So hypothalamus, pituitary to thyroid to the T3, T4. Just another example of that. So your pituitary gland, if you look at it, this is the pituitary gland. We have an anterior and a posterior. We know that the anterior pituitary gland does a lot more, per se, than the posterior. The posterior regulates antidiuretic hormones or vasopressin, and it also regulates oxytocin. So oxytocin is what gets stimulated to release breast milk, but it is also our love hormone. So anytime that you go out and you meet new people and you have an automatic bond with them, you're releasing oxytocin. We will be touching on that posterior pituitary gland with the ADH. Majority of the function of the pituitary gland is with the anterior, and that's going to be your thyroid, growth hormone, your follicle stimulating hormones, testosterone, estrogen. Adrenocorticotropic hormones, so your adrenal glands, where you get the cortisol, you get other things like your fight or flight response as well. Luteinizing hormones, so a lot of your sex hormones, and then prolactin. So you see here we have our hypothalamus, and then right below that is the anterior and posterior pituitary gland. Posterior, we're going to talk about with the antidiuretic hormone, either having too much of it or not enough. And then anterior, we're going to focus on our thyroid, our parathyroid, that is not necessarily stimulated by that, but is on the back of the thyroid. And then our adrenal glands. Starting off with our posterior. So diabetes insipidus. We hear this and we automatically kind of assume, oh, it's just diabetes. Well, that's not what's happening. Diabetes insipidus is due to being deficient in antidiuretic hormone. So permanent or transient deficiency in the synthesis of antidiuretic hormone, or our kidneys not being able to respond to antidiuretic hormone. So ultimately, diabetes insipidus means that we do not have antidiuretic hormone. Now, what is antidiuretic hormone? So antidiuretic, anti-peeing hormone, anti-urinating hormone. So if we do not have that hormone, we are peeing tremendous amounts of fluid. Now, when we think about the scientific aspect of ADH or the patho behind it, what ADH is actually doing, it is putting an aquaporin onto the cell membrane so water can get inside the cell. If we do not have ADH, we do not have the aquaporin going on the cell for the water to go in, so there is no water in the cell. What's happening? The patient's drinking and drink because they're so thirsty, and then it's not going anywhere except for right out of them. They are peeing massive amounts and they're drinking massive amounts. So primary diabetes insipidus is a defect in the hypothalamus or the pituitary gland, resulting in decreased antidiuretic hormone production or releasing too much of it. Secondary, so primary is always the gland itself. So that the posterior pituitary gland, something has happened to it. Maybe head trauma, maybe there is cancer, now there's scar tissue, maybe the posterior pituitary gland was damaged somehow, and now they're no longer able to make that antidiuretic hormone. So primary is always the gland itself. Secondary diabetes insipidus, caused by a disease that affects the posterior pituitary. It could also be traumatic head injury, neurosurgery, or cancer. So secondary is always something outside of the gland that has caused it. I always say if the neurosurgeon is a secondary issue, his hand goes in and grabs it. It's not the gland that's the problem. It's something outside of the gland. So diabetes insipidus with the posterior pituitary, we do not have enough ADH. We do not have enough of that anti-peeing hormone. So we are peeing a lot. Patient cannot stop urinating. The patient will have up to 30 liters of urine within 24 hours. It is going to be low specific gravity, meaning it's severely diluted and probably just clear. Patient is going to be dehydrated. Why? Because there is ADH is not there. It's not putting the aquaporin on the cell so that water can get inside the cell. So the water is going in the body straight through the entire GI tract and out through the bladder. So patient is dehydrated. You're going to see increased urine output. Patient's going to be severely thirsty. There's going to be hypotension because they don't have enough fluid. They're dehydrated. And they're sodium is going to be concentrated. Now, what happens if you have too high of sodium? Could you have things like a seizure with diabetes insipidus? Absolutely. So I have a little story. When I was working at a big hospital, I had a patient that was going to go down for some type of scan. It was like 15 years ago. I can't remember. All I remember, it was horrific. I walked into the room and I knew she was MPO status, and we had actually to shut off the water to her sink because she had diabetes insipidus from a psychiatric medication. So we had to turn all the water off, but we did not turn the water off on the toilet. So I walk in and this poor woman is drinking out of the toilet. That is how thirsty they are. They cannot retain that water though, so it comes right out of them. So there is a constant cycle of them drinking and peeing. Their sodium becomes abnormal and it puts them at a high risk for seizures. So our action alert from our book: ensure that no patient suspected of having a decrease in ADH is deprived of fluids for more than 4 hours, because these patients cannot reduce urine output and they also will have severe dehydration. So I do remember that she was MPO, but it was just I think she was going down for like a CT or something. It wasn't anything major and it had only been like an hour, and within that hour, she could not restrain herself from drinking out of the toilet. That is severe. So how do we treat it? Well, we give them they're missing antidiuretic hormone, so we want to give them antidiuretic hormone so that they can put aquaporins onto the cell and put the water in the cell where it needs to go, so they're not dehydrated. So what is a synthetic of ADH? It is desmopressin, and we can give it by nasal spray, tablets, or IV. And once we give that first dose and we notice that if they're not getting better, we can give an extra dose. However, after that second dose, you're going to call the doctor if they're not getting better. Patients, this is out in the community. Patients do need to carry this with them if it is a common reoccurrence. They need to have it on them at all times, because they do not, something happened to maybe their posterior pituitary gland, they cannot make ADH. So they are going to have to carry desmopressin with them. And again, one dose, not better, they can get 2 doses, but after that second dose, they need to go to the doctor. In the hospital, you're probably going to see it be given IV vasopressin. But we have to be very careful, because if we give them too much of desmopressin or vasopressin, we're going to be adding too much water. We're putting too much ADH in them, and then we're adding H2O to the cell, so that's going to put them on fluid overload. So that can induce hyponatremia when they go into fluid overload. So if they don't have fluid and they're peeing everything out because they don't have ADH, they're going to be hypernatremic. Now, if we give them their desmopressin and they take too much of it, they're going to go on fluid overload, and now their sodium is going to drop. Now remember, do we want that sodium to drop too quickly? Absolutely not. So we're going to be monitoring for things like seizure, coma, respiratory failure, and we need to make sure that if they're in the hospital, that we're not moving that sodium level too quickly. Now, the opposite of diabetes insipidus is syndrome of inappropriate ADH. So this is when we have too much antidiuretic hormone. Diabetes insipidus, we don't have any antidiuretic hormone. Syndrome of inappropriate ADH is we have too much of that anti-peeing hormone. So what happens when we have too much ADH? Well, we have too much aquaporins putting fluid into our cells, and we're not peeing. We're anti-peeing. So now we have too much of that. Now we're not peeing at all. So no peeing, decreased urinary output, increased urine osmolality makes you retain fluid. Fluid volume overload, hyponatremic. Dilute plasma and hyponatremia is going to ultimately can lead to seizures, coma. You can start to hear them start sounding wet in their lung sounds. They're going to be very edematous. So what are we going to do for this patient? Well, we would probably want to put them on a fluid restriction. We do not want to give them more fluid. We're going to look at their edema, monitor their skin integrity. If they're walkie-talkie, lots of their fluid's going to be in their extremities. But if they're laying on if they're bed bound, we want to make sure that we're turning them, because if they're bed bound, that edema is going to cause them skin breakdown on those prominences, those bony prominences. And a lot of times that's going to be on the sacral area. They're not going to be peeing. They're probably going to be very hypertensive because there's too much pressure in their vessels. And they're going to have decreased sodium. So level of consciousness could be an issue. So SIADH means we are going to see a soaked inside, sodium is down. Now the treatment for this, we want the TT to go pee-pee. So we want them to pee all that fluid out. We're going to give them a vasopressin antagonist. That's going to be your tolvaptan orally or your conivaptan IV. Vasopressin antagonist, remember vasopressin is a synthetic form of ADH. Well, we want to give the opposite of that, so the antagonist. So vasopressin antagonist, your TT to go PP, tolvaptan, we especially use this for hyponatremic patients so that we are not getting rid of the sodium, just the fluid. Remember, we do not want to change that sodium level too quickly because it will demyelate the neuron and can't come back from that. So tolvaptan has used less frequently. It has a black box warning. A rapid increase in sodium greater than 12 in 24 hours equals CNS demyelation, which equals death. It can also cause liver failure. Diuretics can also be used, and we need to be careful, but we can use hypertonic IV fluids. So hypertonic is salty fluid. We can give them some salty fluid because they're hyponatremic. We have to give it slowly, and we need to make sure that we're giving them something to pee out. So drug alert, administer tolvaptan or conivaptan only in the hospital setting so that serum sodium levels can be monitored closely for the development of hypernatremia and other complications. So a quick overview. ADH deficiency is diabetes insipidus, excretion of large volumes of fluid. Think about my patient drinking out of the toilet because she was peeing and drinking. Nothing was being absorbed into the cell. ADH replacement is warranted, and it is called desmopressin. Now, if we have too much ADH, that's SIADH, syndrome of inappropriate antidiuretic hormone. It's going to occur with head injuries more than likely, lung cancer, neurosurgery. It is the patient retaining too much fluid. They have too much adding H2O to their body, antidiuretic hormone, and that's going to dilute that sodium down to make them hyponatremic and hypoconcentration. All right, moving into our thyroid gland. So the thyroid gland is really, really important for metabolism and energy. When you think of a hypothyroid versus a hyperthyroid, I really want to paint a picture for you. So hypothyroid, their metabolism is down, their energy is down, everything is slowed down. So when I picture hypothyroid, I think Eeyore. You know, Eeyore off of Winnie the Pooh. He's kind of chunky. He's kind of depressed. He's very slow. But Eeyore is sitting on the beach wrapped up in blankets. Why do I have this picture? Because everything is slowed down. He's in one of the, what we consider a bright sunny place that could be hot, and he has a blanket around him. Temperatures are slowed down. Heart rate is going to be slowed down. Their metabolism is going to be slowed down, that they start to gain weight. He's chunky. So everything is just slow. Thought process is slow. Where on the flip side of that, hyperthyroid, think of Tigger. Tigger is bouncing off the walls. He gets irritated very easily. So he can eat and eat and eat and still not gain any weight. He loves being out in the snow. He will be out in that snow naked because he is so hot. All right. Keep those pictures in your head. So metabolism and energy come from T3, T4. That is what your thyroid secretes. It also secretes calcitonin, but we'll get there. T3, T4 are the hormones that maintain your metabolism and energy. How does T3, T4 get released? Well, the hypothalamus tells the pituitary gland to stimulate the thyroid, and then the thyroid releases T3, T4. There's a caveat though. We need to have iodine in our diet to make T3, T4. So, how do we get iodine in our diet? Iodized salt. Yes, we all say we need to monitor our salt intake. That is very true. But we do need to have iodized salt so that we can make T3, T4. So the pituitary gland makes the thyroid gland work via the stimulating hormone, which then stimulates the thyroid gland to release T3, T4, and we need to have iodine in our diet to make those hormones. Now, remember I said thyroid gland also does calcitonin. So calcitonin puts the calcium back into the bone. So the thyroid gland does secrete this. Let's say your patient has a high calcium level, blood calcium level. That means that more calcium is out in the blood and not in the bone. Our thyroid gland can secrete calcitonin to push the calcium to be reabsorbed into the bone. So you're hypo, not enough T3, T4. You're hypometabolizing. Think about primary versus secondary. Primary is always the gland itself. So what would be a primary issue that causes hypothyroid? It could be Hashimoto's autoimmune disease, where the destruction of the thyroid gland starts off as a hyper. You're stimulating, you're releasing all the T3, T4, but as the tissue dies off, there is no more tissue to release those hormones. So that would be a hypo primary reason. Secondary reason would be anything outside of that gland. So if we do not have T3, T4 being secreted, maybe our pituitary gland got injured and is no longer stimulating that thyroid. Now on the flip side, hyper, having too much T3, T4, we're hyper metabolizing. This can be caused by a primary reason. Could be that initial onset of Hashimoto's autoimmune disease, or it could be Graves' disease, which is also an autoimmune. But Graves' disease is an autoantibody that attaches itself to the stimulating hormone from the pituitary gland. So think primary reason of having too much T3, T4 could be also, I always say, a primary issue where there's too much hormone is likely from cancer, having a tumor stuck on the gland itself, and that tumor is squeezing all of that hormone out. Another primary issue could be strangulation. So your patient, if you work in the ER and you have patients coming in with domestic abuse or what have you, and your patient is strangled, they literally have that thyroid being squeezed and all the hormones coming out. Secondary cause could be, again, maybe there's a tumor on the pituitary gland. Remember, tumors always make you secrete more hormone. So if there's a gland on the pituitary gland, it's going to produce more stimulating hormone, which is going to stimulate the thyroid to produce more T3, T4. And then also, it could be that your patient is taking synthroid or levothyroxine. So maybe they're hypothyroid and they're on synthroid. You take it every day in the morning. You do it before you eat or drink anything with a full glass of water. And I have always said, make sure your patient is checking their heart rate before they take their medications. If their heart rate is like 150 at 5 a.m., they don't need to be taking that levothyroxine because that's a sign and symptom of hyper energy metabolism, hyperthyroid. So maybe their dose is too high and they need to have it brought down a little bit. So some things to consider. Hypothyroid. You don't have enough T3, T4. It could be from long-term Hashimoto's, which is an autoimmune where the autoantibodies attack the thyroid gland itself. At first, they're going to be hyper, but as the gland dies off, it cannot produce T3, T4. It could be the diet, not having enough iodized salt in their diet. It could be having the gland removed, where your hyperthyroid is taking too much levothyroxine, or it could be Graves' disease, where they have those autoantibodies attached to the stimulating hormone, and it's kind of attacking the thyroid to release more T3, T4. Now your symptoms, remember hypo, everything's slow. Hyper, everything's fast. So with hypo, decreased energy. They're sleepy, but if they have sleepiness and it continues to increase, we want to call the doctor because this could lead to something called myxedema coma. Decreased vital signs. So the temperature is going to be, they're going to be cold, their heart rate is slow, respiratory rate slow, their vital signs are ultimately slowed down. They're going to be constipated, chubby, they're going to have decreased cardiac output, so they're going to have the C's going on with them, cold, constipated, chubby, and cardiac decrease. They're also going to have hypercalcemia. And either one, hypo or hyperthyroid, they have a chance for a goiter. Now your hyperthyroid, everything is sped up. So they have increased vital signs, increased energy. They are running a mile a minute. That is Tigger. He's bouncing all over. He's hot. He's irritated. So their GI tract is increased. Their eyes are going to be bulging out of their head. Now, I kind of consider what happens when your eyes are kind of bulging out of your head. You have some edema there. It is going to take a little bit more time and more effort for those eyelids to close over them. So it's kind of like they have slow blinks when they have the exophthalmos. So eyeball lag. They have hypermetabolism. They can eat whatever they want and lose 5 pounds. So they have the H's going for them. They're hot, they're hypertensive, they're hollow, they're haggard, they're very hungry, they're hyperactive. This one has hypocalcemia. So our diagnostic studies, things that we need to monitor for thyroid, we call it a thyroid panel, but it is our thyroid stimulating hormone that comes from the pituitary gland and our T3, T4 that comes directly from the thyroid gland. So with a hypothyroid, a primary issue, there's going to be increased TSH because there's nothing wrong with the pituitary gland. The pituitary gland is like, hey man, why aren't you releasing that T3, T4? I'm going to stimulate you more and more and more. However, if it is a secondary issue, maybe the pituitary gland is broken or no longer working, then the TSH is going to be decreased and the thyroid's not going to be stimulated. Ultimately, the T3, T4 is going to be decreased. For your hyperthyroid, TSH is hopefully going to be decreased. TSH antibodies can be present if it is Graves', which is an autoimmune disease, and T3, T4 is going to be increased. How do we diagnose? So we're going to do labs, but we can do ultrasound and do an iodine level as well. What do we treat it with? So your hypothyroid, we're giving Synthroid or levothyroxine, which is a synthetic of T3, T4. Treatment for your hyper is PTU or methimazole. You'll see either one of those. You can also see radioactive iodine being used, thyroidectomy, getting rid of the thyroid itself. However, if we get rid of the thyroid, they're going to be hypo and be on long-term levothyroxine. Things to remember, never palpate or squeeze the neck area because that's going to push out more T3, T4. And it can send them into a complication called thyroid storm. So thyroid storm is when we have way too much T3, T4. Some signs and symptoms of that is, yeah, they were once had high energy and irritability, but now it is 10 times worse, where their temperature is raging hot. A 1-degree temp in your hyperthyroid patient that is probably sick in the hospital is detrimental to keeping them alive. So if your patient comes in and they have the flu, but they are also hyperthyroid, we need to be monitoring their temperature routinely, because a 1-degree temperature, let's say they went from 99 to 101, they could be thyroid storming. And the problem with that is their heart rate is escalating, their blood pressure is escalating, they're at high risk for seizures because they're hypocalcemic, and everything is, you're not having good cardiac output. So dysrhythmias leading to like ventricular defibrillation or VTAC, ultimately it can lead to death. Or on the flip side to this, hypothyroid, it comes to this, everything is severely slowed down. So blood pressure, heart rate, temperature, they could be hypothermic. We're going to get them some warming blankets. Severe lethargy leading to a coma. They're going to have poor attention span. Some things to remember with this, they're already slow. Everything about them is slow. So we are not going to give them anything else that's going to make them slow. That includes a benzo, a beta blocker, anything that's going to slow them down even more. What we do have to have at bedside for these patients is suction and emergency trach kit. So myxedema coma, severe lethargy, drowsiness, memory issues, poor attention, constipation, everything is slow. When they hit where it's slowed down so that now they're in a coma, you're going to see massive edema, mental status changes, flaccid heart muscle, it's no longer beeping or beating, dilated ventricles, decreased perfusion to the brain and other body organs. So hypothyroid just means that we're deficient in T3, T4. Everything is severely slowed down. Big things that we look for are respiratory depression, bradycardia, and level of consciousness. Your drug alerts for your patient and your priority boxes that are in your book. So teach patients who are beginning thyroid replacement to take the drug exactly as prescribed, not to change the dose or the schedule without consulting their doctor first. So it is a priority for you to know how that this medication needs to be given. Levothyroxine should be taken with water on an empty stomach 30 to 60 minutes before a meal in the morning. There are several drugs that are going to reduce the absorption of the medication, so we are not taking anything with our levothyroxine first thing in the morning. Things that will disrupt absorption: iron, calcium, and antacids. You need to take those separately, and it needs to be spaced by 4 hours. Now, your patient with myxedema coma, our priority is maintaining airway, replacing fluids with hypertonic saline, so your 3% salty fluids. Replace T3, T4 by IV. Give glucose as prescribed. You could need corticosteroids to help with the swelling and inflammation. Check temperature hourly. Monitor blood pressure hourly. Provide warm blankets. Monitor level of consciousness. Turn every 2 hours, again with the edema. There's going to have lots of skin breakdown. And they are going to have aspiration precautions, so always make sure you have suction at bedside. Myxedema coma is going to lead to shock. It can lead to organ damage because we're not perfusing. Everything is slow, and that's going to lead to death. So you're going to assess for hypothyroid at least every 8 hours. You're going to look for severity, mental status changes, temperature changes such as decreasing, and then report any of suspicious findings to the doctor. So our treatment of choice, of course, we're going to be making sure that our patient is outside walking, making sure that they're eating lots of fiber with fluids. We're monitoring their skin for breakdown. They're going to have really heavy menses, so monitoring for anemia, and educate on how to take that medication. It is going to be lifelong levothyroxine replacement therapy. So give on an empty stomach in the morning at the same time every day. And I always like to add, make sure you're checking the pulse rate, because if the pulse is elevated, that means that they're starting to go hyperthyroid. The patient's going to need to have thyroid panels done regularly, every few months, to make sure they're on the right dose. And how do we know that the dose is too high? Well, they're going to start to look like they're hyperthyroid. Their heart rate's going to speed up, they're more irritable, they're losing weight. This is an example of myxedema, who's severe swelling, and it's going to be all over the body. Just make sure we know that our emergency care. So if our patient is maybe not taking their thyroid medication correctly, or maybe they get sick, maybe something's happening, and we start to get concerned about myxedema. Well, myxedema could turn into a coma. So things that we need to be have on hand and be ready for. So maintaining that airway. Everything is extremely slow. Replace those fluids with normal saline or hypertonic. Levothyroxine IV. Glucose IV. Corticosteroids IV. Check the blood pressure and the temperature. Warm the patient. Lots of times you could probably, if it's a nice facility that likes to spend money, they'll have bear huggers. Turn the patient every 2 hours, monitor level of consciousness, and always have aspiration precautions, so suction and emergency trach kit at bedside. Hyperthyroid. So everything is elevated with hyper. They're not sleeping, they're irritable, they're running 100 miles per hour, they eat and they don't gain weight, they have diarrhea, they're hot. So how do we treat it? We can give them PTU, methimazole. We can treat them permanently with radioactive iodine or thyroidectomy. So remember, in order to make T3, T4, we need iodine to make those hormones. So what happens is they make the component, and they make a capsule pretty much of radioactive iodine. That iodine goes straight to the thyroid and destroys the tissue from the inside out, so there is no more thyroid gland. So iodine's needed to make that T3, T4. They make it radioactive, and that radioactive component kills the thyroid from the inside out. So after this, they will be hypothyroid and need lifelong levothyroxine treatment. PTU metamethasone is more daily medication. And then your thyroidectomy, if you take the thyroid out, you're not making thyroid hormones, it'll be lifelong treatment with levothyroxine. Another caveat to this is don't forget your parathyroid is on the back of that thyroid gland. So if you remove that thyroid gland, you're going to have you can still keep your parathyroid, but the electrical components of it may not be working at first. So you might see your patient go into a calcium issue. So with hyperthyroid, things that can cause it would be Graves' disease. So Graves' disease is that autoimmune disease that attaches those autoantibodies to the thyroid stimulating hormone from the pituitary gland, and it kind of overstimulates the thyroid to produce too much T3, T4. Another action alert, do not ever palpate a goiter. You're going to see more goiters with hyper than hypo, but they can both have goiters. We never touch it. The goiter, if you palpate on it, it's going to push more hormone out of that thyroid, and it could send them into a thyroid storm. So, thyroid storm, this is a complication of having too much T3, T4. Everything is sped up. So the heart rate is going haywire at this point. They're at high risk for dysrhythmia. Their temperature is rising. Their blood pressure is rising. Everything is at max capacity, but on the flip side of that, they're not getting good cardiac output. There's at risk for seizures. So things that we need to monitor. Remember, it is a quick onset. So increased heart rate, respiratory rate, and hypertension. An increase in 1 degree of temperature is dangerous. So your patient's at 99 degree temp and they go up to 100, that is not a good sign. Things that we need to do, maintain that airway. We're going to do the 4P medications. So PTU or methimazole, prednisone, potassium, and I can't think of the other one. Sorry. Potassium, propranolol to slow things down. So give iodide solution, non-salicylate, antipyretic, and glucocorticoid steroids. Propranolol to slow that heart rate down and to vasodilate them. Monitor cardiac dysrhythmias. Those vital signs need to be monitored every 15 to 30 minutes. Cooling blankets and ice packs. Correct dehydration. The 4 P's for thyroid storm: prednisone, PTU, propranolol, potassium. So let's say your patient goes and they get a thyroidectomy. Well, we know that they're going to ultimately end up with hypothyroid and have to take levothyroxine. But in the meantime, just immediately post-op, they are going to need their airway protected. You're going to have to be monitoring for things like stridor. Monitor for dressing if there is extensive drainage or bleeding or hematoma formation. That's going to block the airway. They could also be bleeding out. If the dressing is too tight, don't forget, anytime you go and get surgery, you're going to have inflammation. So the surgeon puts that dressing on and the inflammation starts to occur after. It may be too tight. So listen for stridor and monitor respirations. Assess pain, give them pain relief as needed. Semi-valors, we're not laying them flat, support their head. Assess that voice, but it's going to be raspy. That is an expected finding. We want to discourage them from talking to allow the area to heal. And we're going to monitor for hypocalcemia. Now remember, they took the thyroid out. Does that mean that they took the parathyroid out? I think the next slide maybe not. Let me see if I can find a slide. Okay, so let's say this is your thyroid. Your parathyroid hangs out like a butterfly on the, like 4 little dots. So if you have a thyroidectomy, they can just move those glands elsewhere. But what happens when we stimulate or move something, the electrical impulses are not going to be occurring. So it's going to be hypoactive for a minute. So from there, the calcium level is going to drop. And what does that look like when you have hypocalcemia? Well, your patient becomes very twitchy. They're at risk for seizures. You go and take their blood pressure, and their wrist starts to flex up. You palpate their side of the cheek, and their cheek starts to twitch. You're going to be looking for those signs and symptoms. So in nursing care, with radioactive iodine. Remember, they're taking the iodine, but it has a radioactive component, and it kills the tissue from the inside out. So it is radioactive. They can go home. They don't need to stay in the hospital for this. So what do we do for our radioactive patients? They should be in their own room, not sharing things. If they have their own toilet, that's great. They're not going to be washing their clothes with anyone. So use a toilet no one else will use for at least 2 weeks. Sit to urinate. Make sure you're flushing 2 to 3 times, or flushing 3 times with the lid closed. Use laxatives so there's no straining. It also will help get rid of some of that radioactive material. Wash your clothes separately. Avoid contact with pregnant women, infants, and young children. Now your parathyroid gland. Remember, your parathyroid's on the back of your thyroid. This is what regulates your calcium. So if it's high, you have hyperparathyroid. If your calcium is low, you have hypoparathyroid. Now, do not forget, if calcium is doing one thing, phosphorus is doing the opposite. So it can consequently regulate phosphorus as well. So parathyroid makes the parathormone stimulated by calcium levels. So if it is low, we're going to be pulling calcium from the bone and the kidney. It works in partnership with the thyroid gland. So if the thyroid gland gets stimulated saying, hey, the calcium is high, calcitonin from the thyroid gland gets released and puts the calcium back into the bone. Hypoparathyroid leads to hypocalcemia. Caused by removal of the parathyroid gland, could also be caused by thyroidectomy, but not for long term. Could be idiopathic. It could be low magnesium issues. Remember, calcium and mag, they're like cousins that like each other, and phosphorus is that one that likes to rat on you all the time, does the opposite. So whatever calcium does, magnesium does, and then phosphorus does the opposite. Hyperparathyroid leads to hypercalcemia. So that's your stones, groans, thrones, bones, psychiatric overtones. Anytime something is hyper secreting from the gland, I like to say that there's probably a tumor there. It doesn't mean that there always is, but it could be a tumor. That tumor is pushing on that gland, and it's going to start secreting more hormone out. So caused by an adenoma or carcinoma, neck trauma, strangulation, motor vehicle accident. It could be a vitamin D deficiency. Remember, we need vitamin D so calcium gets absorbed. If there is no vitamin D, calcium's just out there in your blood, not being absorbed. And it could also be due to kidney disease. So your signs and symptoms of hypoparathyroid. That means that you're twitchy. You've got your neurons are going into withdrawal from the calcium. So you're going to see paresthesia, muscle twitching, Charlie horses, tingling, numbness, high risk for fractures because the calcium There isn't enough calcium to be absorbed into the bone. Risk for seizures, trachos, and Schaafstek. Tetany is the biggest thing that you'll see. Now, your patient is going to be at high risk for cardiac dysrhythmias. One of the dysrhythmias that you'll likely see is torsades de pointe, which can lead to VTAC and then go into ventricular defibrillation. So with your parathyroid, you're always assessing for calcium dysregulation. So looking for those hypocalcemia, looking for seizures, looking for fractures, looking for twitching or tetany. How do we change it? How do we treat it? Well, we want to increase the calcium, but it needs to be calcium that doesn't have a lot of phosphorus in it. Now, we like to say milk has an abundance of calcium in it, but milk also has, and a lot of your dairy products also have phosphorus in it. So just make sure you're doing your dairy products in moderation, because if we put too much phosphorus in, it's going to do the opposite of what we intended it to do. It's going to keep the calcium low. So yogurt, milk, processed cheese in moderation, and teach that this is a lifelong disease. I don't know if you've ever had to take calcium supplements, but they are the worst. People would complain that they hurt their stomach. So just be mindful. Maybe take it with food or at night when they don't feel all those symptoms because they're sleeping. Take it with a full glass of water. So they need more calcium. Administer calcium gluconate. You can also make sure that they're getting activated vitamin D so that they absorb the calcium. Now, hyperparathyroid equals hypercalcemia. They're going to be increased blood pressure and heart rate, increased risk for bone breaking, confused lethargic to psychosis, decreased peristalsis, so leading to constipation, muscle cramps and weakness, anorexia, nausea, vomiting, kidney stones, and abdominal distension. I like to just say the stones, bones, groans, thrones, psychiatric overtones. That's the easiest way to remember your hypercalcemia. So our nursing care. Either one of these is going to have QT dysrhythmias. So you're going to be monitoring. So if you have hypocalcemia versus hypercalcemia, either way, that QT interval is going to be disrupted. So then you're going to need to be monitored on a telemonitor. If they have too much calcium, we kind of want to have them pee it out. So give them fluids and give them a diuretic. But be mindful of your diuretics. If we give them hydrochlorothiazide diuretic, that's going to keep the calcium in their system. That's not one that we want to choose. We would probably want to do furosemide with this patient. So encourage fluids about 3 liters a day. If they're in the hospital, you probably put them on IV fluids with a diuretic so they pee all that calcium out. Cranberry or prune juice to acidify the urine and decrease stone formation, and strain urine for stones. Get rid of the calcium. You can also, so we talked about the Lasix and the IV fluids, but the other option is to give calcitonin. Now, we can force it, it's going to force it into the bone. Hopefully the thyroid's doing it, but if they've had a thyroidectomy, maybe it's not. So we can actually do that for them. But biphosphonates could be given. Most of the time, patients don't really like taking them, but it has phosphorus in it. And remember, you increase the phos, you decrease the calcium. Now, your adrenal gland. Your adrenal gland has layers to it, and we're going to look at the adrenal cortex. The cortex secretes cortisol. So, ultimately, your adrenal gland also it does a lot. So your fight or flight response, it regulates salt, It helps with sugars, with your steroids, your sex hormones. It does quite a bit. And if you look at it, the adrenal glands sit right on top of those kidneys. So we see the layers down here of the adrenal gland. And we focus on, if we're going to focus on cortisol, we're going to focus on this nice little pink layer. That is the cortex for cortisol. Now, if you look over here, it also does your mineralocorticoids. So that's your aldosterone, your glucocorticoids, so your cortisol, your androgens, so your estrogen, testosterone, your catecholamines, epinephrine, norepinephrine, and then your growth hormones. So the two that we focus on are your mineralocorticoids and your glucocorticoids. Now, what is aldosterone? Aldosterone is part of the RAS system. It gets secreted so that we can either get rid of or retain the fluid and the salt, or it stops being secreted so we get rid of the fluid and the salt. And then your cortisol is a stress hormone. It helps regulate our body when we're in stress or having physiologic activity so that we can stay going, really. So anatomy and physiology, a pair of small, highly vascularized, triangular-shaped organs that are located on the superior pools of the kidney, lateral to the lower thoracic and upper lumbar vertebrae. You can barely see it, but it's just right here. It sits right on top of the kidney. They are teeny tiny. They're about a 1.5 inch. That outer portion is called the cortex, and the inner portion is the medulla. The medulla is your fight or flight response. So the outer cortex, this is where we get corticosteroids. It's about 90% of that gland. It is essential. These steroids are essential for life-sustaining activity. Hormones synthesized and secreted by the cortex are steroids and consist of mineralocorticoids and glucocorticoids. So our glucocorticoids is your cortisol. And think about, we can take steroids orally or give them IV. And why are we taking them? Well, we want to decrease inflammation. We want to maybe inappropriately abuse them for muscle mass, increase metabolism. But also, they can have some caveats. If we have too much cortisol, what happens? Well, the inflammation gets kind of go haywire, and now your body needs it to continue to go. So you can't just stop taking them. Your immune system drops. Your bones start to have lesions. Your hair, you start to get bald. All these things start to happen. That is if we abuse those steroids. Now your mineralocorticoids, your aldosterone, think salt and water. We secrete aldosterone because aldosterone is the chef pasta. He's cooking his pasta and he's throwing some salt in his water to cook that pasta. He's adding salt to his water. So aldosterone adds salt and water to the body. If we decrease aldosterone, we're getting rid of salt and water from our body. So our mineralocorticoids, your aldosterone, key in maintaining adequate extracellular fluid volume. It's a part of your RAS, so renin, angiotensin, and aldosterone system. Release stimulated by decrease in extracellular fluid volume. And renin acts on plasma proteins to release angiotensin 1, which then goes to the lungs to release the angiotensin 2 by the ACE hormone. And angiotensin 2 stimulates the secretion of aldosterone, which results in sodium and water retention. You are going to be so sick of the RAS system. The RAS system is always going to come back and bite you. You need to kind of have an idea of what it is and why we have it. And ultimately, it is a fluid and blood pressure regulation. If we don't have enough fluid, RAS system gets activated, aldosterone gets released, and our kidneys keep the sodium and water. Maybe we're going to vasoconstrict a little bit so that the fluids go to where they're supposed to go, like our organs. Glucocorticoids, most abundant and potent is cortisol. So 92% of circulating cortisol is bound to a plasma protein. Cortisol has permissive effect on other physiologic process, so it could be in combination with your catecholamines, with your fight or flight, your epinephrine and your norepinephrine. If you guys had me for a farm, running through that forest, remember that Barbie show that we played? The Barbie's running through the forest. Well, her fight or flight response gets kicked in. Well, cortisol kind of helps with metabolism, making sure that we're alert and oriented. It works with your catecholamines. Think about taking a test when you have your next nursing exam. You have cortisol release. Now, what's the problem if we have too much stress all the time? We have cortisol released too much. And what does that look like on our patient? They get kind of fluffy. They're kind of angry. They're irritable. They're retaining water. Maybe they have a headache. Also, your cortisol helps control carbohydrate, lipids, and fat metabolism, regulation of inflammatory response, and our immune responses. We don't really want to touch too much on your adrenal medulla. You kind of should have touched on that earlier, but your norepinephrine and your epinephrine. So norepi is your noradrenaline. It is increasing the heart rate and blood pressure, helps the body respond to stress and danger, contributes to that fight or flight response. Your epinephrine is also called adrenaline. It is the primary function, it is the primary hormone in your fight or flight response. So increases blood flow to the muscle, helps with, some vessels are going to be vasoconstricted, so organs get perfused appropriately and vasodilated, and some organs being really alert and aware of what's happening. So the difference is between having not enough cortisol and having too much cortisol. If we do not have enough cortisol, it is called Addison's disease. If we have too much cortisol, it is called Cushing's disease. So the whole purpose of cortisol is managing how the body uses carbs, fats, proteins. It keeps inflammation down. So think about your patient that has upper respiratory and asthma exacerbation. They take a steroid to help with inflammation in their lungs so that their bronchioles stay open. It helps regulate blood sugar, but if we take in an excessive amount, our sugars get too high. It controls our sleep-wake cycle. And it boosts your energy so that you can handle stress. I like to talk about that sleep-wake cycle, especially since you guys are going to be nurses, probably working night shift at one point or another, or you probably already work night shift on the floor if you're already an LPN or working as a tech. So your sleep-wake cycle is supposed to be cyclic. It's supposed to have a certain rhythm, and we hopefully have it in a structured routine. But those night shift people probably do not, because especially if you have family, your rhythm gets out of whack. That means your cortisol, your melatonin, all of your hormones probably get out of whack. Now, so let's say we're on a day shift schedule. We're on a tight routine. We wake up, we go to school, we study, we eat dinner, and go to bed, do it all over again. Okay, so we wake up because melatonin is no longer secreting by like 5, 6 a.m. and cortisol starts to be secreted. Cortisol starts to speed up our heart. It helps us get a little bit more alert. So we do need some cortisol. It gets us going. By dinner time, though, hopefully our cortisol has backed off a little bit and our melatonin starts to seep through around like 8, 9 o'clock when we want to go to bed. We have full melatonin production and no cortisol production. So cortisol has good benefits for us, but if we are not on a routine schedule, if we're awake during the night when our body's trying to secrete melatonin, but we have to stay awake, cortisol is getting released, and it kind of goes all haywire. Off my soapbox. So sorry. All right, so Addison's disease, no cortisol. A lot of the times, Addison's disease is a congenital issue. Ultimately, it can be life-threatening. It is decreased cortisol, and your patient with no cortisol. So think about what cortisol does in our body. Keeps your heart rate going, keeps you breathing, keeps you alert, keeps blood pressure up, keeps fluid status going. Now, if you don't have any cortisol, your heart rate's going down, your blood pressure's going down, your fluid status is going down, your alert status is going down, everything's dropping. So decreased cognition is the first sign that something's going on. They're going to be pretty skinny, lots of weight loss. They are going to have this bronze skin. Think about the previous president that had Addison's disease was JFK. JFK had this nice golden glow to him. It wasn't because he was outside tanning. It was because he has hyperpigmentation from his Addison's disease. Your Addison's patients are going to be tired all the time. Remember, we need cortisol to keep us going. They have lots of GI issues, nausea, vomiting, diarrhea, loss of appetite, decreased weight, decreased fluid, decreased salt, all kinds of stuff. Now let's look over here on your Cushing's. So we have too much cortisol. Do not forget that too much cortisol can be an adrenal gland issue, but it could also be from somebody taking steroids long term. Think about your COPD patient that is 90 years old and has been on steroids for the last 10 years. Could they have Cushing's disease? Yes, absolutely. What do they look like, your Cushing's patient? They're going to have thin skin, easily bruising. They're going to have that moon or round face, humpback, so on the back of their neck they've got a little hump. Hyperglycemia, too much sugar because they're always hungry. Decreased immune system. Increased energy, they're kind of irritated or irritable. They got that roid rage going. Rapid weight gain, so they have lots of fluid, they have lots of edema. They are also very salty. They do have purple striae on their extremities that are very thin, so thin arms and legs, but their trunk is round, obese. So how do we diagnose the two? Well, cortisol level. We can also do adrenocorticotropin hormone, or ACTH, stimulation test or level. We can get a CT scan. We can look at their blood pressure, their fluid status. We can look at their androgens. Do they have gynecomastia? Do they have hair? Does the woman have hair growth on her face? Is their menstrual cycle irregular? What is their salt and potassium? What's their sugar like? So with Addison's, cortisol is going to be low. We can stimulate. So if we have Addison's disease, your pituitary gland is going to have adrenocorticotropin hormone stimulation. It's the hormone that is going to stimulate the adrenal gland to release cortisol. So if we try to provoke it and stimulate the adrenal gland or pituitary gland and nothing's being released, we know if it's from the pituitary gland, if that ACTH is low, the pituitary gland is an issue. If we have this, but no cortisol, we know that the adrenal gland is the issue. CT scan. What's a CT going to tell us? Is there something wrong with the adrenal gland? Is it missing? Is it just scar tissued? Is it no longer working because it's all scarred up and calcified? Or does it have a tumor on it? A pheochromocytoma? That is what sits on top of the adrenal gland, and that's going to make them hypersecrete. With your Addison's disease, remember everything is low. So their blood pressure is low. Their fluid status is low. Their androgens are low. When we do their BMP or CBC, increased kidney function or decreased kidney function, increased nitrogenous waste. Their electrolytes, you do need to know their electrolytes. So with Addison's, they are hyponatremia. Remember, they're hypovolemia, hyponatremia, hypoglycemia. And whatever salt is, potassium does the opposite. So hyperkalemia. What kind of diet do you think this patient, I always kind of correlate what their diet looks like to kind of help me with what their electrolytes look like. So your Addison's disease, they do not have fluids, they do not have salt, they do not have sugar. So could we give them a fast food meal? Probably. Do we recommend that? No. But this is how I remember it. They're going to have probably some type of fast food meal. I'm going to go with Pizza Hut. They're going to have that salty slice of Meat Lover's pizza that has all the carbs, all the cheese, all the salty meat on there. And then they're going to get a big glass of soda on the side to replace their sugars and their fluids. Now with your Cushing's, let's see, their blood pressure is high, their fluid status is high, their androgens are high, their salt is high, their sugars are high, and then their potassium is low. So they can't have any salt. They need to decrease their sugars, but they can add some potassium. So I always think in my head, with a Cushing's patient, let's give them some Mrs. Dash. Mrs. Dash, or a salt substitute, has no salt, but it has potassium. So they can season their lettuce because they don't need any more carbs. Not really. I'm just painting a picture for you. But so they can season their lettuce that they have with some salt substitute, because they can't have salt, but they can have some potassium. Now your corticosteroid testing, one of the big ones that you should always remember is cortisol testing, your dexamethasone suppression test. That is a test. You give them 1 milligram of steroid at bedtime, like at 11 p.m., and then you check their cortisol level in the morning. If it is high, that means, like abnormally high, that means they're Cushing's. If they have no steroid, that means they're Addison's. We shouldn't be secreting cortisol at night. That's why this is one of those tests. If we give them a boost of cortisol and they metabolize it too quickly and then they don't have any left, they're probably going to be Addison's. But if we give it and it maintains and it keeps building and building and building by the morning, they're going to be Cushing's. Now our complications with our cortisol. So with Addison's, if we don't have any steroids, everything is really slow. We don't have salt, we don't have sugar, we don't have fluids, we don't have a blood pressure, and then ultimately it's going to lead to we don't have a heart rate. So Addisonian crisis means that we do not have enough steroids and the patient is high risk for circulatory collapse. No fluids, no heart rate, no cardiac output. Their potassium is high, so we want to get rid of some of that potassium. We can give them Kxalate so that they stool out all of that potassium. We could, I know some people will say, give them insulin, bring their potassium, or no, don't, they're hypoglycemic. Don't even think that. Now, with your Cushing's, the complications is too much cortisol. And really our biggest concern is immune system. So they're going to be immunocompromised. They're going to be high risk for getting an infection. Lots of times you'll see these COPDers that are long time corticosteroid use and they end up with pneumonia. So immune complications. They're also going to be high risk for bone breaks, hip fractures, diabetes. So more of your long-term complications. So what's our treatment? With Addison's, we have low salt, low sugar, low fluids, high potassium. So we're going to definitely give them the steroids that they're missing, but we're going to bring that sugar up with glucocorticoids. We're going to give them salty stuff, so increase that salt intake with some fluids probably. Replace aldosterone, keep the salt in the fluid. Decrease in estrogen and testosterone, so we could give them some hormone replacement. And then with our high potassium, decrease potassium intake or give Kxalate. With your Cushing's disease, yeah, we want to kind of say they need to stop taking steroids, but maybe if you had to choose between your COPD patient that's 90 years old, that's been on this for 10 years, and them maintaining an airway, the cortisol or the airway, I would say choose the airway. So it is not our responsibility, thank goodness, as nurses to make that call about their steroids, so just keep that in mind. Another consideration is do not abuse steroids. That will help a lot. So ketoconazole inhibits cortisol synthesis. We can also do surgical management. So if there is a pheochromocytoma, a tumor on that adrenal gland that is causing hypersecretion of cortisol, maybe they need to get that removed. For hyperglycemia, we're going to do diet and lifestyle changes. So decrease sugar, monitor sugar, do not eat simple carbs. For their salt, we're going to lower their salt intake. Remember, it's 2 grams a day. Their fluid status, we don't want to hold fluids, but if they're looking real puffy, we might hold them, put them on restriction. Hypertension, make sure that they are on antihypertensive because we don't want to cause any damage to those vessels. Decrease salt intake ultimately is the goal. Estrogen and testosterone, you're going to see men with gynecomastia, so breast tissue, and women with facial hair or menstrual cycle changes. And then hypokalemia, remember we can supplement potassium, but a good thing to remember to kind of keep it in your head is that salt substitute. They can't have salt, but they can have potassium. And then always remember skincare, because their skin is very thin. It's going to tear easily, so make sure you're using paper tape. Your patients with Addison's disease are taught at a young age that they have to take daily steroids to keep them alive. They also have to have an emergency steroid dose pack. I used to tell my patients all the time, keep it in your fridge, so you know where it is at all times. Make sure you always have a dose on you. So think about your patient. They are high risk for dehydration and for circulatory issues. So decreased cardiac output, low blood pressure. So if they're outside in the Florida heat, they're likely going to use up all their steroids right away that they took that morning. So they're probably going to need an extra dose. Anytime our body is physiologically stressed out, we need more steroids to keep it going. These patients do not have steroids to keep them going, so they have to take it orally or IV or IM to keep them going. So life-threatening events in which the need for cortisol and aldosterone is greater than what is available to the body, they need to be well aware of emergency protocol. Take your emergency dose, go to the ER. If they're starting to get sick, make sure they have extra doses. If they're taking their med-surg exam, of course they're going to be using up some cortisol. So Addisonian crisis can occur in response to any stressful event, such as surgery, trauma, severe infection, especially when adrenal hormone output is reduced. Our nursing management, correct the fluid and electrolyte status, increase their salt, decrease their potassium, increase their sugar. Rapid IV infusion to rehydrate. Correct the hypoglycemia. Give them glucose. Replace the steroids. Treat the hyperkalemia. So insulin and dextrose, make sure that you're giving the dextrose because they are hypoglycemic. Shift the potassium back into the cell. If they're still with it, they're alert and oriented, you can give them Kxalate. This is if they're coming into the emergency room and you notice that things are not going well. Cardiac monitoring. Remember, they're hyperkalemic. So dysrhythmias, daily weights, lots of weight loss, and vital signs every 4. Surgical management. So if it's not necessarily an adrenal issue, maybe it's a pituitary gland issue, a transsphenoidal hypophysectomy, post-op care, a craniotomy. You'll see on the next slide what that's going to look like. So we're going to assess for cerebral swelling, rising ICP, altered level of consciousness, watch target glands for deficiencies, and leaking CSF fluid. So if they have a tumor on the pituitary gland, it could be hypersecreting. I wouldn't necessarily say this is an Addisonian crisis. I think that's an error on my part. But let's say that they're hypersecreting and they need to have that area removed. So it's the surgical removal of the pituitary gland or tumor. So you see here, going on through the mouth, up through the transsphenoidal area, and they're resecting that pituitary gland because it's damaged or sick. So anytime that we're putting something in this patient's in this area, remember, you get inflammation with any surgery. So this is a high risk surgery. So there's going to be lots of inflammation. So you're going to be monitoring neurostatus, vision changes, looking for a CSF leak. Remember your first signs of cerebral spinal fluid leak. You'll have the battle signs. You could have halo sign, severe headache. So check the gauze, put it up to the nose or the ear, wherever you see fluid coming out, and see if there is if yellow halo is happening on that gauze pad. Have that patient avoid coughing or deep breathing hourly. Avoid activities that are going to increase intracranial pressure. No bending over, no coughing, no brushing the teeth rigorously for 2 weeks. They are going to be gently rubbing their gums with probably one of those mint swabs, but no brushing the teeth. Now your pheochromocytoma, this is the tumor that sits on top of those adrenal glands. It's rare. Most of the time it's benign. It's going to cause hyperactivity of the gland. Anytime you see a tumor on a gland, think hypersecretion. So you'll see hypersecretion of your catecholamines, your cortisol, all of the above. Think hypertension, very salty, lots of cortisol, lots of fight or flight, pounding headaches, risk for seizures and stroke. So we want to treat with blood pressure medications and remove the adrenal gland. Hopefully, they can catch it in time. Post-op, the adrenalectomy, you can see here it's laparoscopic. They're going in, they're pumping that abdomen full of gas. And also think about taking away the cortisol on, you have 2 adrenal glands, but if you take one away, you're gonna have to, your other side's gonna have to pick up the slack with all the cortisol and all the epinephrine, the catecholamines. So you do want to monitor your vital signs, blood pressure management. Hypertension is a cardinal symptom of an issue. Glucose testing. Monitor for cardiac dysrhythmias. Strict I's and O's. Of course, their pain management. The patient should never smoke, drink, caffeinated beverages, or change positions suddenly. We don't want anything to overstimulate and bring the blood pressure worse. We want time for healing. We don't want further vasoconstriction. Do not palpate the abdomen with a pheochromocytoma because that's going to cause further secretion of those hormones. 24-hour urine collection to look for catecholamines. And then an MRI CT to locate those tumors. Ultimately, they're going to have severe hypertension, and they're going to before they go in post-op. And then our last section is diabetes. So we should all know what diabetes mellitus is. There's different types. We have type 1, type 1.5, and type 2. Type 1, we say childhood onset, and it is an autoimmune disease. So your beta cell is being destroyed ultimately, where you're no longer making insulin at all. So you no longer have the key. Insulin is the key for glucose to enter the cell. Why do we need glucose in the cell? To make ATP. So if we look here, normal, we have these glucose. We have the insulin receptor. We have insulin. So insulin sits here, opens up the door so glucose can get in. We need glucose in the cell to make cellular energy. If we have type 1 diabetes, that means that we are no longer making insulin because the beta cell has been destroyed. The beta cell is what makes insulin. So the glucose no longer can get through that door because there is no insulin as the key to open it up. So where's your glucose? It's hanging out outside of the cell. You have no more cellular energy. Things start to die off. And then type 2 is where you still make insulin, but you are like throwing glucose at them left and right, and it becomes overstimulated and overworked. Now it becomes resistant. So you'll have some insulins opening the door, but most of them are going to be like, this is too much, I'm done here. And then I always like to add, there's type 1.5. This is more of your type 1, but they're older. This is kind of a new diagnosis that came out around COVID time, probably a little bit before, but we recognize autoimmune diseases occur with genetic mutation in the typical onset of them. So your person carries that gene, but maybe it's not activated yet. And what's going to activate it is any kind of physiologic stress. Could be cancer, could be getting the flu, could be Epstein-Barr, it could be COVID-19, it could be anything. You get that, let's say it's the flu. You get the flu, and then it's like a light switch. The gene, that mutated gene turns on, and then all of a sudden you have type 1.5 diabetes at the age of 40. Where your body's attacking that beta cell. So diabetes signs and symptoms. Hypoglycemia is cold, clammy, level of consciousness is altered, slurred speech. And what do we want to do? Your book says give candy. I will tell you firsthand that if you meet somebody that has altered level of consciousness and I'm with you and you're trying to give that patient candy, I'm going to smack it out of your hand. You're not doing that. Because their altered level of consciousness, they will choke on that candy. What do we do instead? We can give them the glucose syrups that go in their mouth. Being in community health, lots of patients will carry around those little icing tubes that you can use for cakes to write words on cakes with. That can be absorbed into their cheek. They're not going to choke on it. And then if they're in the hospital, we can give them dextrose. With hyperglycemia, they're hot, they're dry, their sugar is high. You're not giving them any candy. If we were in class, we would be watching this. It is in Tampa, so it's pretty cool to watch about how the paramedics are treating. And it kind of puts a perspective in that, a difference between a paramedic and a registered nurse, where paramedic is there to keep them alive until they can get further treatment. So some of the stuff they do may not be physiologically great for the body, but it keeps the patient alive until they can get further assistance. So go ahead and watch that on your own time. Now, your diabetes complications. Infection is the #1 cause of diabetic ketoacidosis. HHS is likely from dehydration, so concentrated blood, hyperosmolality, and has a gradual onset. DKA, infection, rapid onset. HHS, dehydration, slow onset. And if you work the ER, you are going to easily agree with this. Your DKA patient is like, I was just waking up and all of a sudden I didn't take my insulin and now I'm in the ER. Where your HHS has like been living at a glucose level of 700 and they're like, I just have a headache. So when the amount of glucose transported across the cell membranes decreases, the liver increases production of glucose. Remember our stores of glucose in the liver? Blood sugar extremely high. Kidneys are going to attempt to excrete glucose, but it's more glucose than they can handle. So it's going to start to spill out in the urine. This is why when we look at their urine, we can see glucose molecules in it. Oh, we can't visualize it, but when we take it to the lab to get tested, it'll come back with positive sugar. Large amounts of fluid, so water, salt, is excreted. The client's going to be dehydrated. The skin is warm, dry, and flushed. Stored fat is going to start to break down. What happens when we break down fat? What is the byproduct? What is that specific diet that everyone loves to go on because they lose a lot of fat, but they also can lose some muscle. But what are we testing for when we take their urine? Kidney function must be stable to secrete or excrete all the glucose and all the stuff that our body's trying to get rid of. So we do need to monitor urine output. Your kidneys get overworked very easily and they can get injured. Now, ketones. This is that keto that I was talking about. Ketones accumulate in blood and urine. So pH of the blood becomes acidic. Now, ketones are not common in HHS. They're more common in DKA. So patient begins fast, deep, labored breathing. So if our patient is metabolic acidosis, because the breakdown of the fat, we get lactic acid, we get ketones, our pH starts to drop, we become acidic. How does our body compensate? By breathing rapidly. Our lungs are going to excrete the CO2, the portion of acid that they have, to kind of hope and pray that the pH goes up a little bit. We call this Kussmaul's respiration. It's in order to eliminate carbon dioxide and prevent forming a carbonic acid that will ultimately make the blood more acidic. Untreated or ineffective treatment of DKA and HHS, we all know, leads to death. So, signs and symptoms of diabetic ketoacidosis. Primarily, type 1 diabetes is the bigger component of DKA. Type 2 can also have DKA, but it's more prominent in your type 1. You will see ketones. It's a byproduct from the breakdown of that fat being converted into sugar. So it's the waste product. So you have an extra amount of ketones, which are making your blood acidic and are coming out in the urine. A blood sugar around 300 or more, a pH less than 7.35, bicarb less than 15. Why is bicarb important? Because it's one of those buffers that helps the pH go up. But as you see, it is low. dehydration, and then the 3 Ps: polyuria, polydipsia, polyphagia. When they breathe on you, it smells extra sweet and fruity. And the Kussmaul's respirations to breathe out some of the acid. So our DKA treatment: fluids, insulin, bicarb, potassium. What kind of fluids are we going to give? More than likely your patient's dehydrated. So what does their cell look like? Probably all shriveled up, right? So we want to give it hypotonic fluid. We want to make the cell kind of get bigger, like a hippo. We have to monitor for fluid overload, and this is important. So you give them the hypotonic fluid, you're monitoring for fluid overload. When blood glucose level reaches 250, you can then transition to 5% dextrose and half normal saline. This is going to prevent hypoglycemia and also prevent cerebral edema from making the cells too big. The patient's likely going to need almost 10 liters of fluid replacement if they're in full-on DKA. The blood is thick due to all the sugar, the dehydration, and the polyuria. Insulin, blood glucose could be over 600. HHS, you'll typically see a higher number than that. The pH of the blood is going to remain within normal limits until the ketones the fats start to break down. Insulin will lower blood sugar and stop the body from breaking down fat. Why? Because it's allowing glucose to enter the cell. If we give them insulin, the glucose can now get in the cell, and the body's like, oh, I don't need to break down any more fats for sugar. We want to decrease blood glucose slowly. So 50 to 75 per hour. Unless DKA is mild, and then you can give insulin by continuous IV. DKA is considered resolved when the blood glucose level is 200 or less. Why are we giving bicarb? So we know why we give the fluids, because they're dehydrated and they're sick. We know why we give the insulin, because they don't have any. But why are we giving them bicarb? Because of the acidosis. We want to bring that pH up. So only for severe acidosis if the pH is less than 7. Remember, you can die with a pH of 6.9. So yeah, you need that bicarb. DKA resolved when bicarb is greater than 18 and the pH is greater than 7.3. And then, of course, potassium. So insulin and correction of acidosis with bicarb and fluid will decrease that potassium level. So insulin takes glucose and potassium inside the cell to be inside the cell. So we need to replace the potassium, especially if you see it just start to drop. Monitor for dysrhythmias as well. Now your HHS, typically seen with your type 2 diabetes, there's no ketones. How do you tell the difference between type 1 and type 2 or DKA and HHS? DKAs, typically your type 1, they have ketones because they're breaking down fat. They don't have insulin. And the sugar, their body's thinking we need more sugar. HHS, they have some components of insulin. They do not break down other fats, so they don't have they don't have ketones. It is a more gradual onset. Blood sugar is going to be high. These are your patients that are coming into the ER, and you take their sugar level, and it's over 700, and they're like, I just have a headache. I don't know what's going on. Their pH is probably normal. They're not breaking down fat, so they don't have these ketones. They don't have the acids. So their pH is normal, but their dehydration is the problem. What's our treatment with HHS? So pH is normal. There is no ketones. We're going to monitor for cerebral edema Neurologic impairment, so level of consciousness, pupil changes, seizures, paralysis. If any of those are happening, of course, you're calling the doctor. Drugs that are going to lead up to HHS include steroids, diuretics, seizure medication, so your Dilatin or phenytoin, beta blockers, calcium channel blockers. Conditions that could lead to HHS: myocardial infarction, sepsis, pancreatitis, and stroke. So, what kind of fluids are we giving? Because remember, they are dehydrated. Bolus, then rehydrate. The goal is to rehydrate and get that blood glucose level to within normal limits by 72 hours. So, 36 to 72 hours. Infuse 1 liter an hour until your blood pressure, central venous pressures, and urine output are stable. You want to reduce 100 to 200 milliliters an hour. What do we consider normal blood glucose levels when we start to slow things down? Is 250. So yeah, your HHS patient is probably going to get some insulin. They don't have enough of it, and we need to get help with some of that sugar. Just enough so that preventing ketones. So blood glucose is much higher in HHS. We're going to administer insulin after adequate fluid replacement. So fluid are always first, especially with your HHS. Administer insulin until glucose is about 250. They're going to get regular insulin IV, even though that they may not take insulin on a regular basis. Maybe they're just on metformin outpatient. The patient that has a glucose level of like 700 needs some help. So we're going to give them IV insulin. You're still doing it very slowly. So 50 to 70 milligrams per deciliter per hour. And electrolytes. Monitor every 1 to 2 hours. You're concerned for hypokalemia. They need to be on a cardiac monitor. Now, anybody that's a diabetic knows that there are certain rules for sick days and stressful days. So, sick day rules: check your blood glucose level every 2 to 4 hours. This is, let's say you have the flu. You need to monitor your blood glucose levels more frequently. Check for ketones in the urine, especially if the glucose is creeping up. If your glucose is greater than 240, you need to be looking for ketones. Especially if the glucose is above 240 and there's nausea, vomiting. Prevent dehydration. So 240 to 360 milliliters of sugar-free liquid every hour. Now, you need to have at least 2 liters of fluid at minimum a day. Eat meals at regular times. Take insulin and anti-diabetic medications as ordered. Treat the nausea, vomiting, diarrhea per physician order. We don't want to have a lot of it. Rest and call the doc. So, if we are checking our sugars every 2 to 4 hours and we're rehydrating as we should at 2 liters a day, but we start to notice there's ketones in our urine and the glucose is creeping up, and it's creeping up even though we're taking the insulin, we're going to call the doc. So, things that we get concerned about: nausea, vomiting that's persistent, moderate to high ketone amount, high glucose even after 2 doses of insulin, low glucose after eating sugar, or a high fever greater than 101.5 for over 24 hours. Now, what's the difference between DKA and HHS? DKA is type 1, has ketones, and it has metabolic acidosis. HHS is type 2, and it's likely from dehydration. Sugars are higher. We need to treat with fluids and insulin. So, DKA is the result of no insulin, so therefore you go all the way into acidosis. We treat with fluids, insulin, bicarb, and potassium. HHS, this is the result of limited insulin, so therefore the patient stops before they break down fat. They still have insulin, just not enough. Their sugar is high. They are dehydrated. we treat with fluids and then insulin. And that is it, my friends. Be on the lookout for your oxygenation lecture.